Welcome everyone. Today we're talking about cardiac masses, which is a lot nicer as a topic to present than congenital heart disease, which is what I presented last time, just because this is much more simple. So what I'm going to do is put up my slides, which I will try and do now. For those that don't know me, I'm Ben Gerhardy. I'm one of the physicians at the hospital. I've got one victim in the room and a few victims online. So this is a session that is hopefully going to be a bit more interactive than some of the other ones I've done, just because I think cardiac masses lends itself to that pretty well. The idea is I'm going to run through half a dozen slides of just some general information about cardiac masses, just a sort of a bit of a framework of things to think about when you're seeing them, and then just run through a few cases as well. The cases are pretty short, they're not tricky in any way, and I'd love to have some volunteers to sort of go through those when we get to them. The best way to get ready for the DDU exam is to do cases. I guarantee it. I've done it twice, so I know for sure. All right, here we go. Great. All right, so a few slides on an approach to cardiac masses. So first thing is to define the mass. Like, where is it? What's it look like? And do you think it's going to be benign malignant? Overlying all of this, though, is, and this down the differential thing, is it actually real? Okay. You think about things like, why did you come across this mass? Is it because it's causing some degree of obstruction? Is there some myocardial involvement? Has it flicked stuff off? Is there constitutional symptoms that can lead to this? You're thinking things like malignancy, for example. But at the end of the day, you want to try and work out what it is. So the common things are common, right? And so anatomical variant is virtually always going to be differential for a cardiac mass, at least for most of them. Is it thrombus? Is it vegetation? Is it artifact? Outside of anatomical variant, it's those three that are your key three differentials. The other stuff happens, but those three are the things that you're going to see by far and away much more commonly, all right? Tumors occur. I've got a couple of slides on those. Implanted devices occur. Some of those have quite a unique echo profile, and you get used to seeing that. Otherwise, is it real? Is it thrombus? Is it vegetation? Is it just a normal variant? So you can approach them anatomically, if you like. So move that out of the way. Good. So thinking about from an anatomical structure, like, is it in the left atrium? You can think of things like a pectinate muscle and Marshall's ridge, or the Coumadin ridge, as it's also called. So that is normal variant, right? That's normal anatomy. In the right atrium, we think of things like the crista terminalis, eustachian valve, the Chiari network, all those things that are effectively phenal remnants, but in some patients can be really, really prominent. If it's associated with the valve, you're thinking of calcifications or excrescences like Lambles. If it's within the left or the right ventricle, you think of a moderator band or a false tendon, moderator band in the right ventricle, false tendon in the left ventricle, especially in the apex of the left ventricle, papillary muscles, non-compaction. Pericardium have cysts and fat, and then a few other random bits and pieces. So you'll see, if you start looking for it, quite a lot of patients that have a lipomatous hypertrophy. You can see atrial septal aneurysms. You see them nice and mobile, especially on a toe. And of course, a hiatus hernia is another thing that you can see on a transthoracic that can sometimes look like it's sitting within the pericardium. In terms of devices, things that you can stumble across, right? Pacemakers, ICD leads, chances are you'll know about those because you can feel it externally. Right heart catheters, hopefully you know about that. Occluder devices, you catch those in a few patients, as well as prosthetic valves. So occluder devices can be to occlude off an interatrial septal defect. You can also get occluder devices for the left atrial appendage. All right, thrombus. So thrombus in the old textbooks, is reportedly pretty common, but I think in practice we don't see it a whole lot. However, undoubtedly, some of that will be because of better revascularization strategies, right? Get in there, you fix the LV, and the chance of developing thrombus is less. However, some of that is almost certainly because we don't go looking for it hard enough. In an anterior MI, it'll be apical, sitting right at the tip there. It can be quite subtle on occasion, and you really need to do off-axis imaging to try and pick it up, as well as maybe contrast. And I've got some cases with that. Within the left atrium, appendage, of course, that's not surprising. Within the body, the left atrium as well. So if you're doing a toe, you can see thrombus sometimes within the left atrium itself. So it's really important to fan through all planes on the toe. So by probe manipulation, moving the probe itself, as well as changing the omniplane angle. And don't forget, you can get thrombus in the right atrium as well. Again, there is a right atrial appendage, for those that don't know. Catch thrombus in transit, so that might be coming from the vena cava into the right atrium. right atrium into the right ventricle, or even across an interatrial septal defect. And of course, anything associated with the catheter or line can have clot, vegetation, that sort of thing attached to it. Yeah, ask questions. Why don't you?
Is that because like concrete's not significant because it doesn't like the clot doesn't go systemically unless you've got like a
So for those that couldn't hear, Umi asked about looking for the right atrial appendage, for thrombus in the right atrial appendage. So you're right, we don't often go looking for the right atrial appendage and looking to check if it's clear of thrombus in most standard cardioversions. But there's probably an argument that we should, because the blood will be stagnating in that fibrillating atrium just as it will be in the left atrial appendage. So identifying the RA on a toe is, it's very much doable, right? It's some slightly different views. It takes a bit of practice, but it's doable. It also quite often has a different configuration. Like we talk about the left atrial appendage having a few different configurations. The right atrial appendage can have a couple of different configurations as well. It's got a broader neck rather than a narrow neck. So theoretically, blood will have an easier way of like swimming in and out of it, as opposed to that left atrial appendage is often quite like long, almost cylindrical. Right atrial appendage is broad. So, it will have stagnating blood within it, but it does have a bit of a better washout in that sense. But yeah, no, we should be going looking for it at least. And then there's certainly case reports of people getting thrombus in there. But you're right, it won't go off to the systemic circulation. It'll just go to the lung. A couple of facts about vegetations. So vegetation is on the upstream surface of the valve. So that is, blood flows atrium to ventricle to aorta, or atrium to ventricle to pulmonary artery. So upstream is the first part, right? So it'll be on that potentially lower pressure side. You can get vegetations opposite an intracardiac shunt. So if you've got a VSD or even ASD and you've got blood flowing through that's got bacteria in it, where that blood's hitting the opposite wall, you can get shunts there. You can get vegetations developing there, so endocardial vegetations. And they'll look like a mobile and oscillating sort of bit of tissue. Typically have a different density, and it is freely mobile. That's the catchphrase that we love to hear, especially from a DDU perspective. If you've got a mass that is attached to a valve and is independently mobile, you have to be thinking of vegetation. Almost always they're going to be infective, right? We know that. IE is relatively common in the environment that we work in, but they can also be non-infective as well, right? So be associated with autoimmune and connective tissue disease, and they look like vegetations, they act like vegetations. They're just not caused by bacteria. And they can calcify when they're healed up. A couple of slides on cardiac tumors before we get into some cases. So primary cardiac tumors, so we're at primary and secondary. So primary cardiac tumors are rare. Okay, they're rare, and that's really important to remember. If you do see something that is going to be a primary cardiac tumor, it's much more likely to be benign rather than malignant. So benign ones, about 3/4 of primary cardiac tumors are benign, and of those, about 3/4 are myxomas. Then the rest are a bunch of random stuff. PFE, so papillary fibroelastoma, is another thing that you might see a bit. The others are pretty rare. Of the malignant ones, sarcomas are the main group that you'll see. The mesothelial lining can lead to tumors as well, so mesothelioma. So myxomas, so a benign primary cardiac tumor, they will be almost always sporadic. They can be associated with some congenital, or not congenital, some genetic syndromes. But women 30s to 60s, I'm not going to say it's middle-aged, 60s middle-aged, 30s are still young. Someone that is now 40 years old, we'll say. And most of them are in the left atrium near the fossa ovalis. So I'll put that graphic up there just to show where the fossa ovalis is, for those that have forgotten, to get an idea where you'd be looking anatomically. And there's the two stills that are there. There's obviously a big one sitting in the left atrium on a toe image, and then a big one on the right. So you can see it's quite a well circumscribed mass. It looks almost like an egg or a big marble. You can find the stalk on them, so you can find where they attach, and they'll move and oscillate around a bit. Think about the valvular complications if you have one that's crossing the valve. So PFE, papillary fibroelastoma, these are predominantly left heart. These are these small, generally, well circumscribed little masses that will be attached to a valve. They generally don't cause any valve issues like regurgitation, like we see with significant, infective endocarditis, and you have the vegetation, you get significant regurgitation often. These generally don't do that. And theoretically, there is a risk of these actually embolizing, often causing damage, upstream. I've not seen that. I've just read some case reports about it. And this is just a nice little graphic I saw that shows sort of where they come from. So see, the majority are on the left heart, aortic valve and mitral. Then the rest are sort of a bit of non-valvular and everywhere else. And that little picture down here, I really like this. That's what it looks like when it's been cut off. So that's a centimeter, right? See, that's that frond palm-like structure. And that's what they look like when you actually pull them out and have a proper look. And then that's what they look like when they're on valvular tissue, like a little warty, nubbiny thing, I guess is the best way to identify them or to try and recognize them. You'll see these not uncommonly. Sometimes you can really try and work out, it can be hard to work out if it's a PFE or a bit of calcification on the valve. It can be really hard to try and distinguish between the two. I don't have any tips to do that. Old imaging is useful, thinking about the risk factors of the patient, the patients on dialysis or end-stage renal disease, those sorts of patients that are going to have like thickened and calcific valves, probably just that. But if you find this and nothing else, or a structure looks like that and nothing else, think PFE. Malignant primary, so these are rare. These are the pretty uncommon things. Sarcomas, and they'll typically spread elsewhere. As you probably all know, if it's a sarcoma, it's almost always a bad diagnosis. And of course, any tumor associated with the heart is, generally speaking, a worse prognosis on top of that. Secondaries can come from anywhere, and they're much more common than a primary. So 20 to 40 times more common than primaries. And some studies say, like, I can't say, as a respiratory physician, I can't say that I see this play out in practice, but some studies show up to 5 or 10% of all patients with solid organ malignancy have some degree of cardiac involvement with that from the malignancy itself, as opposed to like drug effect. Breast and lung, because they're quite close, anatomically speaking. Melanoma, because that can go anywhere. It can be direct spread. It can be hematogenous spread, or via some venous structures. And certainly some of the renal and uterine tumors are really pronounced in doing that, just going straight up the IVC and causing a whole lot of right heart havoc. All right, cases. That's it. So that's the first 15 minutes. That's all the boring stuff. We now have half an hour or so of cases to run through. So it'd be great to have some volunteers to go through this. Umi, because you're sitting here, do you want to be the first victim? Sure, great. I'm not sure if you're in shot. All right, you may even know this patient.
This is the apical chamber view.
Yep. Sorry, 1 second. People online, can you guys hear Umi speak?
Okay.
Right. Come closer.
The image on the left is the apical four-chamber view.
Yep.
And can't really see the right side of the heart, but the LV that we can see, there is regional wall motion abnormality. The apex is basically akinetic. The base is hypokinetic. The mid segment is essentially the one that's maybe hypercontractile or hyper.
So we're saying here is working good, bad.
Good.
Yep.
Good.
Base is
Hypo.
yeah. Apex
is hypo/akinetic.
Yeah.
Can't really see the endocardial border well.
Yeah, exactly.
So can't really comment anything further beyond that.
Yep.
And then that is the
That's a parasternal short.
parasternal short, and it's at the level of the apex, I
Yep.
think.
Cool.
I'm tempted to say that I can see in both views, but you can't really be certain because the quality is bad and can't see the endocardial border that there is a mass within the apex.
Okay. This will all start playing. All right, so what's this? What's this study, first of all?
It's a contrast study.
Yeah, exactly. And what's contrast?
It's just ultrasound enhancing agent.
Yep,
It's
nice.
a form of microbubbles.
Yeah.
And then it doesn't depend on any organ or elimination, so an organ elimination.
Yeah, exactly. So for those that don't know, if there's not been a contrast talk already this year, I think there might have been, not sure. So ultrasound enhancing agents, or ultrasound contrast as we call them. So it's these tiny, tiny, tiny bubbles of like a perfluorine shell, I think it is, and then some gas in the middle that you agitate on a special shaker. I've forgotten the word. That gets this takes it and turns this crystal clear liquid into something that's opaque. You can then draw it up into small aliquots or run as an infusion. And these are these tiny bubbles that when they get hit with the ultrasound waves, they will vibrate differently, and you can see them. It gives this, it shows where flow goes. You have to turn down the mechanical index. You have to turn down the power, because if you have a bit too much power, you'll pop them, which is something that we can use to our advantage at times if you want to see sort of how quickly blood free flows back into certain areas like myocardium. But it's a really good way of enhancing a blood-filled space to define where blood can flow and where blood won't flow. So what do you see on these contrast images?
So this is an typical 4-chamber.
Mhm.
The contrast is basically filling the LV cavity, and we can see the effect in the contrast where there's a circumferential area that just doesn't have flow.
Absolutely. So there's this big black circle in the middle here. That's where there's no blood going. Okay. So this is our LV cavity. You can't really make out the walls, but this is our blood endocardial border that's tracking down through here. It's actually a bit hard to say whether in a 4 or a 2-chamber view. I didn't take these pictures. Probably a 4-chamber view from the look of it. And there's a clear demarcation through here where there's zero flow in this black bit. And that's because that's a dirty big thrombus sitting in this patient. Just as you said. All right. What are you doing now? What are you going to do?
I think it's just confirmatory.
Yep.
That, there is a thrombus.
Yep. So what are you going to do now? You've had a big thrombus in a person. Any coagulate? Oh, yeah. Sounds reasonable to me. Yeah, probably make sure we'll know. Probably make sure the cardiologist know, right? Okay. Do I have a volunteer for the next one?
Can I ask a question?
Oh, yeah, please.
Sorry.
Yeah.
It's about the contrast.
Yeah.
Like, the guideline always say that, you can do it infusion versus bolus, but, they recommend infusion. But I've noticed here the few that I've seen contrast, they're always doing bolus in our hospital.
Yep.
Is that like to save amount of contrast that we're using?
Not necessarily. So when you crack up an ampular contrast, it will keep open for a short period of time. So once you've opened it, you've got it there. I want to say it's 24 or 48 hours it can stay open for. It might be shorter though, so don't quote me. And there's a couple of different contrast brands. So they have it slightly different preservatives and characteristics from that perspective. In terms of running infusions versus bolus, so in the intensive care unit, here when it's used, it will often be administered as a bolus, more for convenience, I think. And when we do it up in the outpatient setting on occasion, often do stuff as an infusion. Yeah, so like for us, for example, we'll put up infusions. Okay. So infusions to give you that benefit of being able to have effectively steady stream contrast, right? Boluses do work. It's just that you can get too many bubbles at first, and then you get some drift off, right? You get some fade as you start to have less bubbles circulating through. So I think the infusions at the end of the day probably work better, but they're a bit more challenging to set up, more equipment and all that sort of stuff. Okay. That's the trade, right? It's the logistics of it. All right. Rishi, you online? I think this is a good one for you. It was. Maybe he's gone. He's clinical today. I know. Yes. All right. Can you hear me? Yeah, I can hear you. Great. So this is a guy that was admitted to me actually a couple of years ago. So 60-year-old guy getting a bit breathless over like 12, 24 months. Actually, so 6 or 12 months, I should say. He'd been a builder, like a labourer kind of active guy. Came into ED after his GP did a chest x-ray that looked a little bit abnormal. What do you see?
Yeah, I think we have a best and long axis view along with two views showing zoom views of the mitral and aortic valve.
Yep.
On the best and long axis view, non-zoom view, the LV function appears to be at least moderately impaired. The chamber sizes appears to be normal. Can't see properly the frame rates, but on the zoom views, the the anterior mitral valve appears to be thickened, and there appears to be a mass attached to the anterior mitral valve along the outflow tract, but I probably need to slow it down and zoom it a bit more to see if
But are
it's
you
a
seeing through
pap muscle
here?
versus this one. Yeah.
Oh yeah,
So it
so
could be a pap muscle or
that's
it
just
could be
corner and
something.
pat
That's a
muscle. Yeah,
pap
it's just
muscle.
ever so
Yeah.
slightly off. Yeah,
Yeah.
yeah. So that's just corner and pat
And
muscle. Yeah,
okay.
yeah.
And along the zoomed aortic valve view, along the at least on the 2D, I can see the cusp opposing
Yep.
in the midline. Normally, there is no obvious prolapse or
Yeah, good.
or yeah,
Basically normal, right?
yeah, normal
Probably a
basically.
bit off, but otherwise normal.
Oh, okay. All right. So on the four-chamber view, the most obvious abnormality is a mass attached to mass in the right atrium. Sorry, the left atrium, um, which is a large mass fixed of homogeneous echogenicity. Um,
Yep. So what are your
and
differentials?
So it's not attached to the intraatrial septum, so that makes some of it unlikely, but it's possible.
Mhm.
Either it is a large thrombus or a mass,
Mhm.
or a possible malignancy is what would
Could
be
it
my
could it be artifact?
assumptions. Um, I mean yeah, I mean it is being there in multiple imaging planes,
Yeah, good.
which will make me think that it's probably not an artifact.
Yeah, good. You're right. Probably not artifact, right? So this is the toe they wanted to have.
Color.
So they want to give you color.
Yeah. Yeah, so this is a large mass attached to the what is the posterolateral wall of the left atrium,
Mhm.
and extending up to the level of mitral valve, and in one the off-axis view in the right lower frame, it's probably extending beyond the mitral valve.
Yeah. Oh, so
Um,
I'll just orient you for a second. So 0 degrees here. This is sort of upper esophageal view, left atrium. Here we're catching some aorta. So here's obviously come down a bit more, around at 40 degrees. So this is here. This is our
Yes.
left atrial appendage. This chamber down here.
Okay, gotcha.
Okay.
Yeah.
So if this is the left atrial appendage, what's this tissue structure through here?
So this is the Coumadin Ridge, which is
Yeah.
there, but there is
Yes.
a
So where's this coming
independent.
from then?
So beyond that is the pulmonary veins, which are there.
Yeah.
But this is probably there in the left atrium, whether it's extending into the pulmonary veins and the left atrial appendage. And
Yep.
there is mixed heterogeneity of mixed echogenicity of it, which makes me
Yep.
wonder if there is any underlying, is there any superadded thrombosis or any other pathological process going on?
Yep. So what would your main differentials be at this point?
I think this is a large atrial mass, which will make myxoma as my top differential diagnosis.
Yep.
But I would like to check if there is, check with color Doppler to see if there is vascularity along with the stalk, to see if they can interrogate a bit more.
Yep. So actually picking up color flow in this using color Doppler can be challenging because it's going to be like small vessels, potentially slower flow. So you can use contrast actually, and some contrast was given. I don't think I have these pictures to see if you have like delayed filling, to see if you can work out where the vascular supply to this thing is coming from, but it didn't help very much.
Yeah.
This is just a still. Okay, so this patient might have a cardiac MRI. And so this is originating from the pulmonary veins, extending into the left atrium.
Okay.
And that's what it looked like after being chopped out. Out in there.
What is it then?
Hey?
What is it?
So they had two independent pathology opinions. One was a sarcoma, of a form of sarcoma, and the other was a form of mesothelioma. They couldn't agree. What surgery did he have done? This is a question I asked my trainees, my baby doctors. This is post-op. What was the surgery?
Pneumo.
Yeah, complete pneumonectomy, right? Incredible. Hey,
Can I ask if you put color on that mass? What scale do you normally use?
Oh, so what I do is I turn the color scale all the way down until it's just like pure color flash artifact. You can't see anything. And, just that red blue screen that comes up, and I then start slowly increasing it until you just find what you need to find, right? Until you see like a pattern in there that tells you it's going to be vessels. You could take the other approach. You could just start really high and slow it down, bring it down. But just go to one extreme and work your way backwards. Yeah.
So probably on the 4-chamber image, if you go back, I think probably they were originating from the left pulmonary veins and not anywhere closer to the intrathecal septum.
Yeah.
Yeah, that's probably the
So
left pulmonary veins origins.
This view here, right? Yeah, exactly right. So this is where we have our left pulmonary vein, and your left atrial appendage can sit in here. I can't see it super well, but yeah, you can pick where it's coming from there.
Nice.
Yeah, that was pretty cool. All right, next one.
So it was the primary originating from the lungs and invading through the pulmonary veins into the heart.
Yes. So
wow.
Yes, probably more the smooth muscle in the vascular structures of the lung was the thought.
Okay.
Yeah.
Wow.
Yeah. Yeah. Incredible. All right. Who's next? Who's up for this one?
I know.
Perfect. Hey, one. Long time no chat. You've been nominated. This is a 35-year-old bloke that rocked up to a peripheral hospital. Actually, you may know or remember this case. I think it was last year. And these are the opening images seen by the sonographer. What are the images and what do you see?
So it's parasternal long axis view, as well as zoomed in view of the aortic valve and collar top lung. There's a lot going on, but I think the most sort of salient features are aortic valve appears sort of abnormal in terms of 2D. So the right the left of the non-coronary cusp appears to be prolapsing, resulting in significant AR, and the LV cavity on subjective assessment appears dilated. On top of that, there is sort of there is echogenic sort of mass. I don't know. I probably should just call it. I'm worried also about there being dissection flap in the ascending aorta. The root and the ascending aorta appears dilated, and there's mobile 2D structures. Yeah.
Nice, good. Exactly right. So we think about cardiac masses, we think of anything that can be within the cardiac chambers, and things like normal tissue, which is really what this is, just normal tissue that has come off from where it's meant to be attached, appears as a mass and can be readily misinterpreted if you don't know what you're looking at. Yeah.
Just with that one, do you mind just like showing to me which one's the cups and which one's like the extra flap?
So what's what? Yeah, sure. Let's get them all playing again. So here we've got a cusp, yeah. And here we've got a cusp. There's a little flippy, that bit there, yeah.
So in this one, is this the cusp or
so this is because they're fanning through as they've taken this shot. So I'll just pause it and come back. So cusp.
That's the cusp.
Cusp, yeah.
Right. Okay.
And then what we're seeing here, what appears here, so imagine the sonographer is sort of fanning through this, and what they're picking up is that dissection flap that is coming down as they're like fanning through. You see them closing off the left ventricle there, right? Yeah. No, all good. They should all play. And so the bottom, this image down here, bottom left, that's the sonographer like starting at the level of the mitral valve in effect and sort of fanning up through, as you'll see, that goes from LV to aortic valve. It's a nice little scene shot. All right, so Haywan, talk me through what you see.
So must be just an off-axis view of the aorta, aortic aorta.
Yes.
maybe a bit high parasternal long axis.
Yeah.
So again, it sort of more or less confirms what I suspected, which is sort of dilated aortic root in the ascending aorta with a dissection flap, and just based on color flow, severe aortic regurgitation. Bottom images, it's a short axis view of the aorta. The aortic valve appears tri-leaflet, and again, I think I'm catching some of the dissection flap there as we're planning.
Yeah, nice. You can see it, like, especially in this one here in the bottom right, you can see that there is a 3 valve cluster, right? And you can see the extra structure just like flicking in and through. And that's what the sonographer has captured really nicely in this view here in the bottom left. So I'll just try and go back a bit. So here, right, so we're still in, like, effectively in left ventricle, kind of interventricular septum, and you got this starting to come through, right? And so that's just our dissection flap, like flicking down through the aortic valve, yeah? So it's popping down through the aortic valve into the ventricular cavity, into the aortic wall. And then these should all start playing in a second. So talk me through what you see here.
So that's that's the apical 5-chamber view. Again, it's a bit off axis, but there's this what appears to be a severe eccentric regurgitation shed. That's the abdominal aorta. The color Doppler across it. And I like to say that is diastolic flow reversal. But I'll need to put the image down to confirm that. But I mean, actually, just on seriousness, so based on just on that color of this, I see some faint blue, which blue should be abnormal. Should be coming towards me all the time. So there's probably some flow reversal.
Yeah, and you can see how there's different, like, it's hard to pick, especially in full speed, right? But you can see there's differential flow, like within the aorta. So there's blue thing here and red thing here, right? So, you know, blue is away from the probe, red is towards. So you can see this flash of red that's coming up here. Obviously, we're in our thoracic descending aorta here. You can also see that there is actually, like, you know, the question is this real or fake? If you just had this view, you'd say, you know, is that real structure or not? It's independently mobile, so it's probably not artifact, right? You know, could it be something else? Could it be a line, right? Like a iatrogenic structure? Yeah, maybe. But then you track it all the way up, and you can see where it's going. You can see there is different color flow across it. Yeah, dissection, type A dissection, right?
Yep.
So really rookie question. The pictures on the right-hand side of the screen, is that subcostal or suprasternal?
So these two over here, these are suprasternal. So it's not always come up to the top there and look down. Certainly, I was seeing sonographers more and more, and it's great. They're more and more taking abdominal aortic pictures. At this, like when I started here, I think we're probably imaging that a bit less. But we're catching it all the time now. You know, always IVC, but this is becoming a more common thing to try and get pictures of, and then they'll pulse it and all that sort of stuff. All right. Anyone have heard this? Back to you, Imi. So I've got 3 people's faces I can see. Haywan, Imi, and Rishi. Imi, you want to back to you?
So this is total image mid-esophageal, and it's at 0 degrees, sort of mid-esophageal sort of chamber.
Yep.
But concentrating on the LV, we can see the aortic valve intermittently.
So it's a bit, so just to, like, for anatomy, kind of like almost like a 5-chamber, right? So we're starting a bit higher with the toe probe, which is why I can still see some aorta. And you can see how the LV during systole, it's really coming in from every dimension, including from the bottom, because we're shortening it, So you have to give some extension to the toe probe to try and get a longer view through it. So it's a short view.
Esophageal then, because we can see it.
Mid to upper.
And the LV function looks
so be really cautious calling on this because you're foreshortened. So everything's been coming in a more exaggerated way. What you want to see is you want to get a view where you've just got your that apex of the LV isn't really coming in much, just the walls, right? Because it overplays it here. It looks like it's almost hyperdynamic, right? And it may be, but you can't really say that from there.
So there's a lot of chaotic, like turbulent regurgitation flow. Can I check the scale? The scale is like low, it's full.
Yeah, I'll spin it over here.
So that's possibly contributing somewhat.
Yeah, nice.
turbulent and chaotic looking.
Yeah.
Just in terms of the mitral valve appearance.
Mhm.
So this is going to be the scallop A2P2.
Always guess A2P2.
Yeah.
If you're not sure, guess A2P2.
Okay.
All right. You're more likely not to be correct.
The A2 looks abnormal,
Hmm.
and abnormal in terms of this just like thickening appearance of the A2 valve.
The A2 skull, so the anterior mitral valve leaflet, yeah?
Yeah. And in terms of the how it correlates with the direction of the regurg,
Yeah. So what if we
it's
slow it down and go?
It's actually anteriorly directed centric.
Just tick it all the way through. So we have it, yeah, coming up through here, right?
Mm.
Coming here and washing around a lot, yeah. Almost like we're losing coaptation here. Yeah, yeah. So it's our anterior leaflet here, our posterior leaflet here. Anterior is the longer one in most people.
Mhm.
Yeah, everyone else, but almost like this is going to be blood just gushing up in through here and then swirling around, yeah. So
Yeah.
if this is our anterior and this is more our posterior, that's the direction of that regurgitation in and around and through. Onwards, move this out of the way.
No, we're just like concentrating, looking at the mitral valve.
100% we are. So this looks totally disastrous, right? So don't worry about the views. Don't tell me what the toe views are. You just tell me what you think of the mitral valve.
It's abnormal.
Yeah.
And there's like incomplete coaptation of
Yeah.
the scallops.
Yeah. Is it thickened?
It's
Is
thickened.
it flailing?
It's thickened at the tip of the
Yeah.
leaflet.
So what's this person got?
So,
Young person, febrile.
So you have to think of infective endocarditis.
Yeah. It's not a trick question, right? It's easy cases. So let's just have a look at this one, yeah? So you can see here, like this just looks raggedy.
Yeah.
Yeah, this is not a nice, clean, crisp line.
Mhm.
This is just a raggedy looking line. It's all a bit grey and sort of heterogeneous. They don't look like it's coapting well. We don't have colour there to be sure of that, but you can see, come forward a few more frames. Again, this is all raggy and not normal looking. If you look at this one here in the bottom corner, bottom right corner, come back and then we got, what is this thing? What is that thing seen there? No idea, right? And so if you watch that bit and now watch it play out in time, you can see how there's something that's flecking up into here,
Yeah.
clearly up into the left atrium, yeah?
Yeah.
It's only there for a couple of frames, but it's clearly abnormal. Oh, gee, like, where is it? What is it? Look at this one again. You know, we're come all the way around at 180 degrees here, so basically inverted the omniplane. And both valves look wrong, don't they?
Yeah.
Like that looks thickened and atrocious. This looks all raggedy and completely messed up. Yeah, this big chunk of stuff sitting on top of it there. Yeah, if you're looking at other views, you know, at 45 degrees, almost like that trapdoor style view, almost around to that, you can kind of think it looks not too bad. A bit thickened in certain views, like in certain frames, but otherwise, oh, that looks pretty good.
Yeah.
In reality, it's like, why you got to check it in every plane? So if you're scanning, got clinical suspicion of something like infective endocarditis or any sort of valvular lesion, forget about what the textbook say, knowing like, oh, I'm going to do 0 degrees and then like 45 and 60 and 90, 120. Like you just go through a few degrees at a time with your omniplane, 5 or 10 degree aliquots, and just look at it, look at it, look at it, look at it, like the whole way through.
Yeah. Because
you'll miss this sort of stuff more than you reckon, like in a scaringly large amount of cases if you don't be slow with it. These, especially for patients' features of IE, are not just a lay down misere of them, right? All right, next one.
So the summary of that, was it the vegetation on?
So she had, they had both anterior and posterior leaflet vegetations.
Okay.
Yeah. For bonus points, about how many, if you've got infective endocarditis on one valve, what's the chance of having it on another valve?
High, especially like from mitral to eye.
What's high? Throw out a number.
40.
Anyone else? If you've got vegetations on one valve from infective endocarditis, what's the chance of having it on another valve?
If it's like mitral, then like to aorta because of your mitral
Oh.
aorta good. And if it's like depends on which valve.
Yeah.
If it's the left-sided, then it's high. If it's right, then probably not so high.
You sure you spoke?
Okay.
So they say sort of 20 to 30% chance, right? If you find a vegetation on one valve, 20 to 30% chance of finding it on another valve. And I'm sure there is a level of detail there that I don't know. For example, if it's Staph aureus, it's probably going to be everywhere or close to it. If it's like one of the sort of classic culture negative infective endocarditis, bacteria that you see, perhaps not, propionibacterium and that sort of thing. Anyway, Rishi, back on to you. 22-year-old woman comes in with some exertional breathlessness. And these are the first few images that the sonographer shows you. Tell me what you see.
I think the most obvious thing is the mass in the right atrium, but apart from that, the LV function appears fine. The IV septum appears a bit thickened.
Do you think the LV function is normal or abnormal?
I mean, LV function, it appears the LV walls appear thickened, but they need to be measured. But it could be, we could have a hyperdynamic circulation going on with a slightly raised EF.
Yeah. So, if you look at this cut, you think, are we truly cutting through the middle of the ventricle? Now, aortic valve looks nice. You're sort of seeing the two leaflets of the aortic valve, but for the LV cavity itself, I think you can probably see a bit too much pap muscle, right? Especially for some of the later cardiac cycles, suggesting that you probably are a bit off axis. You can see that much pap muscle. So if you're a bit off axis, you're sort of slicing through it obliquely, which will mean that it looks a bit more hyperdynamic than what it truly is, yeah?
Yeah.
All right, so, and then you've commented on something in the right atrium. So what's this view called?
Yeah. So this is the RV inflow view.
Yeah.
Pastoral RV inflow view.
Yes.
So you can see the tricuspid valve looks clean. But there's a large mass in the right atrium, a large homogeneous, relatively immobile mass. So let's see.
So what are your differentials
To
of
the
this?
posterior wall. I think this is unlikely to be a congenital or a benign structure. I mean, it's most likely a malignancy. Not clear it's a benign or a malignant structure. But it most likely is a neoplasm.
Could it be thrombus?
Thrombus with the echo texture, which is almost at the equivalent to the walls, is more probably goes in, and in the homogeneity of the echo texture, more goes in favor of neoplasm to me. But it could be thrombus is a differential for sure.
Yeah. So in the DDU exam, you can say, yeah, look, it could be thrombus, but you're more concerned about being like a mitotic lesion, right?
Yeah.
What are the structures that empty into the right atrium?
Yeah, SVC and IVC.
And
IVC and coronary sinus.
yeah, good. So which one's this? Where's it coming from?
So the coronary sinus appears clear, so it could be the IVC.
Yeah, so coming from that angle, that's sort of, so when you're on your RV inflow view, and there's a structure coming from the bottom of the sector up, or sorry, no structure, an inflow, then it's your IVC and your coronary sinus are on that side, and your SVC comes in from the other side. All right. Italy's playing. They should all be auto playing. So sorry, this one up here, the color scale is not great, so it might be a bit hard to appreciate what you're seeing here. Just tell me about the two images on the left to start with, the two that have cardiac chambers on them.
Yeah, so the mix of 4-chamber with sometimes going into 5-chamber views, again showing, confirming those the mass in the right atrium, a large homogeneously echogenic mass attached to the posterior wall of the right atrium.
Yep.
And probably you can see the IVC coming into the picture.
In the images on
the
the
lower left picture.
Yeah, it kind of wants to come in. And then over here, what do you see in the subcostal images? This might be a bit hard to. I think this is much easier to see when you've done a scan. Yeah. So what we've got here, so this is the IVC, and here this is a soft tissue density within the IVC. Okay.
Okay.
And here the sonographer is looking at the right kidney, but I didn't include this for that. I include this just to show this. What's this?
Morrison's sponge.
Yeah, ascites, right? Yeah, so free fluid in the abdomen. So this is a renal cell malignancy. They classically track up the IVC, right? And that's why part of the surgical approach is chopping all that. Yeah. Oh yeah, this one. Hey one. I can see your lips moving, but I can't actually hear you. No, there's no mute. I don't think you're muted either. Yeah. No, I do not know what's going on with that. I could try and lip read this, but I don't think I'll be very successful. Yeah. All right. Moving back to you.
So parasternal long, it's the infralateral wall is probably thickened. And the LV function on this view at least looks at least moderately.
So what walls can you see there of the LV?
Anteroseptal and infralateral.
Yeah, good.
The LV function on this one view looks like it's at least moderately impaired.
Yep.
Not severe.
Yep.
And the mitral valve, it's opening well, but you can see like a flicker of hyperechoic mass within the LA.
This thing?
Yeah, is that? No?
How is that just not artifact?
Yeah, it can't be shown until we have different views.
Okay. How can you make this picture better?
It's with a gain.
Mm-hmm.
So you want to reduce the gain.
Yep, good. What's this thing?
That's the I think, is it below the pericardium?
Yep.
Yeah, it's below, so it's your thoracic aorta.
Yep. And what do you see on the image on the right?
So apical fold chamber.
Uh-huh. I mean, there's a thing there in the left atrium, but it looks like it's moving synchronously with the valve, right?
It does. It's really hard to point where it's originating from.
Yeah.
But it's really moving in synchrony with the cardiac cycle.
Yeah.
So could it be the anatomical variant?
So within the left atrium, your anatomical variants are more things like obviously Coumadin's ridge, like the Marshall's ridge. What's the ridge in Morgani? Don't call it that. What is that?
Is that?
No, okay. You can look that up later. It's associated with something which you don't scan with an echo. So it could be a pectinate muscle, right? So pectinate muscles are those little muscles that sit in the bottom of that left atrial cavity. So you think the left atrium like a chamber, and sort of sitting in the bottom of that is a pectinate muscles. And so when you're doing a toe, for example, and you're interrogating the left atrial appendage, you can sometimes see little structures sitting within the left atrium, and they can be so the atrial appendage, and they can be pectinate muscles, right? But they're typically a small thing sitting at the bottom of the atrium, right? Sorry, atrial appendage, I should say. So you generally you won't see those in a transthoracic view. You won't see the pectinate muscle.
The attachment looks like it's attached to the, I don't know which part of the wall is it, of the LA.
Mm-hmm. So he's still convinced it's real, or could it be artifact?
It's most likely real because we've seen it in two different views.
Yeah, okay. Yep. Good. Exactly right. So if you see more than one view, different plane, you can fan through it a little bit, see if it's still there, and you can do things like put color over it, right? So get asked to cardiovert this patient. What do you think now?
Is this the same patient?
Same patient,
Yeah.
yeah.
So that's the left atrium that we're seeing, and we can see like in the right-hand side, we can see like a bit of the atrial appendage. There is a mass there.
Describe the mass to me.
It is irregular.
Yes.
Appearance-wise.
Yep.
And there's heterogeneity.
Yep.
And it is originating probably from the LA.
Yep.
Invading through the, from the appendage, invading through the LA.
It's coming into the left atrium, isn't it?
Yeah.
Yeah. So what is it? Yeah, it's thrombosis, right? Yeah. So it's coming from the left atrial appendage. It's coming out into the left atrium. And it's a patient that's in paroxysmal AF. Here he's in AF. You've been asked to cardiovert this patient.
You have to cancel it.
Yeah.
Yep.
Good. Correct answer. Do not cardiovert this patient. And perhaps start them on anticoagulation as well. They weren't on anticoagulation.
Through the valve.
Yeah, there's little bits of clot flicking into that LV, right? Off the mitral valve. It looks like it. So again, you want to scan through multiple planes to be sure, but it looks to me like there's a little, the tiniest little stem that's holding. Yeah, see, look at that. Yeah, there. Isn't that horrifying? There's a stroke waiting to happen. It's pretty mobile, that. But you can see how it's dark in the middle as well.
Yeah.
As opposed to, say, the earlier case, which was coming out of the pulmonary veins, which was a much denser, and Rishi's other case as well, a much denser, clear tissue, right? All right, and there's just a few more shots. So you can see it flicking around here. All right. I think I've got 1 or 2 cases left. So, Rishi, back to you.
Yeah, so
Again,
these are all presumed images on the toe.
Yep.
There is along the closer line of the aortic valve.
Yep.
There is a small echogenic, hyperechogenic structure flicking on the ventricular aspect of the valves. And so which will be concerning for either Lambel's excrescences or a small vegetation or a thrombus. But they need to be clinically correlated. But I'll also need to check do additional imaging to see if it's associated with regurgitation or not.
Yep. So what else do you want to do before I show you more pictures? What else do you want to do? What else do you want to see, I should say, from an echo point of view?
So echo point of view, just to see if it is independently mobile,
Yeah,
and
good.
whether it's the closure line or not. Is there any additional, if there is any abscess or is there any perforation of the valve, which shall be worried. This is all based on 2D, and then you can go for color Doppler to look for any valvular or paravalvular regurgitation.
Yeah, exactly. So start to get concise and systematic when asked what else you want to do, right? So if you think about preparing for the DDU vivas, so what else do you want to do? You want to examine the structure, in this case, the aortic valve, in multiple planes. You want to examine it with color Doppler. You're going to then think about getting continuous wave and pulse wave and all that. So just build that algorithm up in your brain to be able to flick through it. You mentioned the Lambel's excrescences. I'd say they're more commonly a sort of filamentous thin structure. If you woke up, you walked in the room. A Lambel's, how would you define or describe a Lambel's?
So Lambel's are anatomical variants that tend to have a filamentous like structure. They tend to be on the downstream surface of the valve rather than upstream. But they can potentially increase embolic phenomena. So they're not always necessarily benign.
Not completely benign, hey. But in terms of how they look, I often see them as like almost like a strand, just a single strand that is coming off and
Yes.
flicking up into the aorta, really, right?
Yeah.
Short.
Yeah.
As opposed to something like this, you know. You could argue, is it maybe something that looks to be coming off the tip there? It's hard to say, but I think the actual tip itself. All right, same patient.
So these are a short axis view from the aortic valve on the top two images. And I think in the introit, in the non-coronary cusp, there appears to be a thickening or a at the middle of the cusp.
Right there?
Yeah, right there.
Yeah, nice.
Which should be.
So if this is the non-coronary cusp, what's this one?
It's the right coronary.
Which means this is the
Left coronary.
Thank you. Yeah. And now, like, these are, I think these can be the challenging cases, right? You go, oh, is this a vegetation? And it could be, but I've only given you one color Doppler shot there. And if you have color on the short axis, which I don't think I've got one of those clips here, you don't see a whole lot of regurgitation. You see maybe you definitely see a flick of regurgitation here, but it's not torrential by any means. The valve itself doesn't look destroyed. It's not a whole lot of architectural distortion and destruction of the valve. So it could very well be IE in the right context, right?
Yeah.
But what else could it be?
I mean, it could be a previous vegetation which is healed or calcified just at the nodule. I don't see a lot of independent mobility on it in the short axis views.
Nice.
And not a massive amount of revegetation.
Yep. So this is PFE, fibroelastoma.
A PFE, yes.
Yeah. This shot down here, there's one where it comes in there, little nubbiny thing there, right? Again, like clinical context is really important here. If you're suspicious of infective endocarditis, positive blood cultures, you see something like this, you'd have to be very cautious in saying it's definitely not infective endocarditis, right? Especially with antibiotics for a few days or a bit longer. Think of the risks and benefits of the decisions that you make in your reports. Yes, there's features against it in the sense that we don't see a whole lot of AR. The rest of the valves are clean. The LV is not hyperdynamic. This thing does not have independent motion, but it's definitely abnormal. Contextualized to your patient.
I think it could be another anatomical variant on the aortic valve. Any volunteers?
Which is nice.
Do you have Lampo's? What is it?
At the risk of sounding very foolish, like can the nodes of Arantius, can they look like that?
Yeah, nice.
Yeah.
Okay.
Probably looks more like that than a Lampo's, doesn't it? Because it does look a little bit nodular.
Yeah, like a lumpy thing, right?
Yeah. But Ben's absolutely right. I think in the clinical context, you've got to treat that as you've got to treat that as IE if that's the clinical question.
Yeah.
Bacteremia and all of that, because the consequences of not treating it could be pretty catastrophic.
Yeah. I find them really hard, those cases, especially when you're seeing them a few days or a week down the track in terms of antimicrobials. So they could very well be a bit pre-treated already, I think this is actually my last case. Hey, do you have audio back?
Can you hear me?
Hey, yep, cool.
Yeah.
So I don't know why some of these, they're all meant to be looping, but some of them aren't.
Yeah, so there are TOE images, sort of short axis view of the aortic valve. I think the most salient features are like the aortic valve appears abnormal on 2D, particularly the non-coronary cusp appears thickened.
Yep.
Actually, all three leaflets appears abnormally thickened. I'd like to look at other views of the other 2D views of the aortic valve as well as color Doppler.
Yep. A young person, right? So old person with significant hypertension, renal disease, all those sorts of things. Maybe you'll get a thickened valve, history of rheumatic heart disease, may have thickened valve, but in a young person with a valve that looks like this, it's very much abnormal. Give it time, they should all start playing, hopefully. All right. Describe what you see.
Yeah. So again, the long axis view of the aortic valve sort of supports what I've seen on the short axis view. So that's sort of right and non or left coronary cusp both appear thickened. On collar Doppler, there is, on collar at least, there appears to be significant or severe eccentric regurgitant jet.
Mm-hmm. Yep.
Yeah.
What do you think of the valve opening in these shots here on the long axis? What do you think of the way the cusps are moving?
Yeah, you're right. They look also appear limited for a 33-year-old.
Yeah. What do you think of this? Not sure if you can see my cursor very well. The structure through here.
Oh,
through
yeah.
Here.
Oh, yeah, I missed that.
And we're seeing some shadowing down here, right? Like this looks
to
flow through here.
Yeah, the aortic root appears thickened, which is obviously abnormal finding. I'm concerned about like a inflammatory pathology, like aortitis.
Yeah, or
you
got an abnormal valve.
Infective endocarditis.
Yeah, and we'll go to that in the aortic position. It's kind of like aortitis. Abscess,
I'm
right?
not sure. Oh,
aortic
sure.
root abscess.
Okay. Yep.
Yeah, so think about aortic root abscess, which can end catastrophically, as I'm sure some of you have seen before, right? This is an infective endocarditis case of the aortic valve, and it's a soft tissue thickening around that root of the aortic valve, which can be easy to miss, you know. It can be very easy to miss. So again, it comes down to using your omniplane to scan through the valve to scan through the structure really in all angles, and flexion extension moving up and down. But yeah, aortic root abscess with the infection. Just a few more pictures. What do you think of the severity of the AR?
It's an eccentric jet. So so the collar. So it's an eccentric jet. Sorry, let me just I don't want to call it severe, but I can't really back myself.
Why can't you back
that's a collar turbulence. I mean, like I shouldn't make assessment on collar Doppler alone. Yeah, but it just looks severe.
Yeah, look. So I mean, yes, there's the textbook ways of saying you've got criteria to meet, right? You know, flow reversal, and you can volumetric stuff, and you can try and get a PISA, and you can get jet height and LVOT height, and blah 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 blah. But when you got an aortic valve that is clearly abnormal, yeah, what do you think of down here, Haywan? So the aortic valve itself.
What are you pointing at?
The bottom right image where we have a sort of 3-chamber view. What do you think of the aortic valve there?
I mean, it's prolapsing. So I think that it's either the left or the non-coronary cusp. It's prolapsing. No, a flail is the answer.
Yeah. So I think it'd be hard pressed to say this is not severe AR. I appreciate the idea to do like certain criteria to meet, and something that's what the guidelines say. But you got a infection, so infective endocarditis of the aortic valve with a root abscess, a flail leaflet, and a color Doppler that just looks atrocious, right? Absolutely atrocious. It's amazing. I mean, you can say, "Oh, is the color scale set right?" Nah, but it's still going to look pretty shocking.
Yeah, 100%.
Is there diastolic MR on the top one, Ben?
Ooh. Let's see, where are we? Just looking at the ECG system here in diastole there. That's diastole there. Our red line is here.
So when you see the AR jet coming back, do you see MR at the same time?
Yeah.
Probably a little bit there. How do you see that?
Yeah. So Emma was just saying that diastolic mitral regurg. So mitral regurg is normally in systole. Good. But if you've got enough flow into your left ventricle from aorta during, because of bad AR, you can have some blood actually flowing back out your mitral valve. So your diastolic MR, and a color M mode through this is beautiful. Faraz has a couple of those that he pulls out every now and then. It's almost like a spot diagnosis, right? If you have diastolic MR, there's a few other conditions you can get it, so some heart blocks and things like that. But yeah, diastolic MR.
Can I ask a question, Ben? Like this shadowing artifact, if you
Cool
is
stuff.
that all this like shadowing artifact?
But from here,
There are at least like two of
yeah.
those. What's that from?
So I mean, this is just the bright reflector here that's causing it. Why there's that, I don't know. Apart from there being a bright reflector, like to lead to that shadowing, whether that is purely attributable to calcification and things around the valve and soft tissue inflammation and structures because of the abscess, I would assume so.
I think so. I think it's just, you calcification.
Yeah.
You sometimes see it at the point where it's at now, because especially in like hypertensive and renal patients, because they tend to get calcification like around the sinotubular junction. That's where it sort of tends to deposit. So you often do see those dropout artifacts when they've got heavy calcification.
Yeah. Good. This is it. Last slide. So quick summary, right? So these are just the pertinent points, and not all this stuff I covered in the cases I went through, but artifacts that you always have to consider, right? So artifacts as well as anatomical variants, but always think about artifacts. So fan through the structures, use color, off-axis imaging, consider toe and alternative other imaging as well, right? So again, falling slightly outside the spectrum of DDU and echo teaching, but CT, like CT angiograms of the, so you can do a CT of the cardiac chambers as well if you really want to get better contrast enhancement of within the cavities, just something you can't see. So there are other ways to image the heart outside of echo. Like I feel like I'm going to be burned at the stake for saying that in this talk. And ultrasound enhancing agents, so contrast and whatnot can be used to help define things as well. But have a short list of differentials. Anything can be, almost anything can be thrombus, anatomical variant, or infection, and go from there. That's it, guys. So any last minute questions that I'll fumble my way through? Otherwise, I'll take silence to be the end.
Thanks, Ben.
Cool.
Then just before you go, just one quick question.
Sure.
Just the differences between a dilated coronary sinus and a thoracic aorta. How would you? What would be your answer to that?
What was that?
How would you on the parasternal long axis? If someone shows the structure which the question you asked for me, which is a descending thoracic aorta going behind the left atrium, and sometimes they can, if what is a dilated coronary sinus, what would be the points of differences?
Which one of them sits within the pericardium?
Coronary sinus.
Yeah. Is the descending thoracic aorta in or out of the pericardium?
Outside.
You have a tissue playing through that way.
So you just have to see. Okay.
Usually
Yeah, so Emma's just said also you can pulse wave it, or you can look, you can pulse it at least, or you can use color to look for that pulsatile flow. So that'd be another way to go about it as well, yeah. But yeah, your relationship to the pericardium is an anatomical landmark you can use.
Just because it's dilated, the coronary sinus, if you do like saline, like vegetated saline when you're injecting, will it always like fill up first before the coronary sinus will always fill up first? No, not necessarily, just because it's dilated, or does it only fill up first if there's a shock?
It only fill, if you've got persistent left SVC or unroofed coronary sinus or something.
then it will
Yeah,
fill.
then it will
Yeah,
fill.
yeah.
Okay.
But otherwise it won't.
That's fine.
Yeah.
Thanks,
Right.
everyone.
Thanks, everyone.